There we go. We're going to enter the broadcast. Okay, good. So we're live. Okay, wonderful. We're going to get started here in the next minute. This is Dr. José Barrera. I'm here with Dr. Lucas Patrocinio and Dr. Tomas Patrocinio from Brazil. And it's just a pleasure to be with both Doctors Lucas and Tomas and speak to you about rhinoplasty as well as how to adjust the profile. Now, many times what we talk about is adjusting the profile has everything to do with getting a good facial aesthetic. The rhinoplasty surgery that we perform does an excellent job for adjusting profile, refining the nasal tip, improving function and breathing. But we often forget about the facial analysis and how the nose relates to the chin point and how it relates to your occlusion and your smile. And so we're going to be discussing some of these techniques in combination. So by way of introduction, I am a facial plastic surgeon, reconstructive surgeon. I've been fellowship trained in maxillofacial surgery and facial plastic surgery, orthognathic and sleep, and I practice in San Antonio, Texas. Dr. Lucas, you want to introduce yourself?
Okay. Hi, first, it's a pleasure to be here with you, Jose. It's nice at this time that we have these interactions. We can talk a bit of different points of view. For me, this live is very interesting, so we can talk about nose and face in a more complete view of the face. My two passions in surgery is rhinoplasty and orthognathic surgery. So I think these are the two most powerful surgeries that we have to enhance facial beauty. And so it's good to talk about rhinoplasty and chin and forehead and face. So we're going to do this today. It's not that common, but as Jose has his training, I have my training also in facial plastic and maxillofacial. And so we hope we can give you, the audience, you guys, a bit of our experience coming. Hi, Tomas. Hi, Tomas.
Hi there. Hi there.
Hi.
Hi, Jose. How are you?
Good, Tomas. And just introduce Dr. Tomas Patrocinio. Tomas, you want to introduce yourself? Tell us a little bit about yourself in the next minute.
Yes. So I'm Tomas Patrocinio. I'm an ENT surgeon, facial plastic. I work most with rhinoplasty and facial plastics. 3 years ago, I did the International Board Federation in the United States, and today I live here in Uberlândia. I work at the same office, my brother, and that's it.
Great, thank you. We'll go ahead and start the presentation then. So. Wonderful. You should be able to see my lecture. Are you able to see my lecture there?
Yeah.
Yes. Okay, wonderful. So what we want to talk about is aesthetic, adjusting the facial profile of rhinoplasty. As I mentioned before, we're going to be discussing the topics of rhinoplasty and how it relates to the overall facial aesthetic. As an overview, we're going to be discussing facial analysis, morphologic profiling, genioplasty operation, and show some cases. Initially, from a skeletal perspective, many of us are familiar with this, and that is cephalometrics. Are you able to see my mouse here? One of the principles we use is the angle between the sella, the nasion, and the point A. Which
I cannot see your lecture. You see, Tomas?
Yeah, me neither.
Okay, let me go back and and share screen here. Okay, we can see that. Okay, I can see all three of you guys. Share screen here.
Yeah.
And let's see here.
I can see your screen.
You can see my screen now. Wonderful. Let's go here. Can you see it now?
Yes, perfect.
You can see the lecture?
Perfect.
Yes.
Perfect.
Perfect. Great. So facial analysis, skeletal landmarks. We often look at the sella nasion to point A. The point A is considered the infraspinale, the point, the deepest depression below the spine, the nasal maxillary spine. And then the SNB is sella nasion to point B. We call this a supramentale, or the deepest depression above the menton. These are skeletal norms within a general population that should reflect an SNA of 82 and SNB of 80. There are many more cephalometric guidelines that we utilize for orthognathic surgery, and we use a dolphin analysis to look at those. But from the basic perspective and understanding skeletal framework, we want to look at these angles because they tell us whether the maxilla is retrusive or whether the mandible is retrusive or prognathic, and the relationship. Secondarily, we match the skeletal framework with our facial analysis, and we're very familiar with the soft tissue profile. And so we can trace the soft tissue profile off the cephalogram, the bony analysis, and derive off the Frankfurt horizontal plane, which you see here, a perpendicular plane. The perpendicular plane, which is driven through the subnasale and the upper lip, is called the Gonzalez-Ulloa classification or relationship. And so in males, you want the pagonion, which is the anteriormost point on the chin, to closely approximate this line, and a female should be within 1 centimeter. We can then translate both our skeletal anatomy with our soft tissue analysis and be able to then relate both of these. So what do I mean by relate both of these? I mean, you want the glabella bony point to reflect the glabella soft tissue point, and you want the subnasale bony point to reflect the point A that we spoke about. And then you want to approximate the menton on the soft tissue with the perpendicular plane that we described, the Gonzalez-Ulloa relationship to this perpendicular plane. So you want to basically closely relate both of these in order to achieve some balance. So this is something we use as a relationship. They're not hard and fast rules. The gonion to subnasale should be within a horizontal analysis of plus or minus 3 millimeters. Same thing with gonion to pagonion relationship. And so you can see what we're looking at here as a relationship. Now, when patients come in and they have, we call it a morphologic profile, which is abnormal, many patients will present as a concave relationship, thus a retrusive maxilla or a prognathic mandible will cause a patient to look retrusive in nature or concave. Conversely, a patient that has a very large nose or overprojected nose, you may find may also have a class 2 relationship in the mandible and be labial, we call this labial version of the maxilla. So the maxilla is labial verted. It can be retrusive, but we can see that the teeth are labial verted and the anterior maxillary spine is more anteriorly placed, and therefore the nose is more overprojected. And so the patient will look as a facial analysis like they have a convex profile, right? Very retrusive chin, they may have a retrusive maxilla, but when you look, they have a class 2 relationship. So the concave relationship is usually prognathic, class 3, the convex usually typically class 2. versus someone who is orthognathic, we describe it, or straight profile, will have an almost even analysis here, right? So when you look at when you look at the gonion, excuse me, the glabella to the pogonion or to the menton point, it's relatively straight, and that's what we try to achieve. So you can see how the nose can be impacted by the underlying skeletal framework. So when do we address the underlying skeletal framework? We can address it with in these patients with concave or convex abnormalities. One of the most powerful tools is a sliding genioplasty. In facial plastic surgery, most of us are accustomed to putting a chin implant, but what a chin implant can do is project the chin point. And with a custom chin implant, we can correct some asymmetry, but you're really masking asymmetry. In a sliding genioplasty, the advantage is we're going to correct under projection, we're going to correct over projection, we can also correct vertical height discrepancies to transverse asymmetries, and can be combined with rhinoplasty surgery. And so this is an example Dr. Chang published in Facial Plastic Surgery a while ago. Some asymmetry can be corrected with performing a genioplasty surgery, and that's what this is trying to show. This is one of my patients, which we did rhinoplasty and genioplasty for. You can see that the patient had some underlying chin asymmetry, but you can see that the nose was also asymmetric. And so our goal was to provide more symmetry to the nose as well as the chin point. And you can see here that the patient was slightly over projected, and he had this more convex profile, if you will. And so this is a patient before and after rhinoplasty and genioplasty surgery, whereby we help to align the nose to the vermilion. And usually what I like to do is align it with Cupid's bow. You can see here there's some asymmetry here, but also align it with tooth number 8 and number 9, which are the midline incisors. So this is a patient that's post-op 13 months after genioplasty and rhinoplasty surgery. And you can see here we were able to give him a more orthognathic profile instead of this convex profile. He's now more balanced because we were able to project the chin point with a sliding genioplasty and reduce the dorsum of the nose with rhinoplasty surgery to achieve more harmony. And you can see how the maxillary spine is less projected, and he has a better columellar labial angle. So you can see here the projection. Now for a male, we do not need to make the chin touch the Gonzalez-Zulor relationship or the subnasally vertical line, but we can closely approximate it, but it makes a big difference in the overall facial aesthetic. You can see here how the patient was convex, and this is something that we need to get accustomed to in facial plastic surgery, to look at the overall face and try to change a convex profile to a more straight orthognathic profile. And you can see here by doing the combination, you get a better facial balance on the profile. This is another one of my patients. We did a rhinoplasty and sliding genioplasty. She had a very long subnasally to menton distance, and she was also quite retrusive. And you can see here that she's more than a centimeter from our vertical subnasally to vermilion relationship, or the Gonzalez-Zulor relationship. She's also overprojected in the nose, and has a dorsal hump. And so we perform rhinoplasty with a sliding genioplasty. The sliding genioplasty was meant to do two things. Was meant to give us closure, or give her of this gap here, so give us a more projected chin, and allow us to be in relationship within a centimeter like we talked about. But we also decrease this mandibular plane angle. So another measurement is looking at the condyle to angle to menton. So that's another relationship, another angle that we use. And so in as much as we could do a clockwise rotation of this mandibular chin point, we can achieve better facial aesthetics. And so in this patient here, we can see here that the that this angle is improved, not just because we move the chin forward, but we actually improve the mandibular plane angle. And so again, the patient here is in this convex relationship, and we decrease that convex relationship by doing a genioplasty surgery, and we corrected the vertical height discrepancy that she presented with this powerful operation. This is something that cannot be achieved with a chin implant. Now, what do you do about a patient that is not convex but concave? And this is a patient we did a revision rhinoplasty and corrected her over-projecting menton, and also helped to balance out her chin point. So you can do this with a sliding genioplasty as well. You can see here that now this patient's chin is over-projected by over a centimeter, so too much chin, but she's also very concave. And you can see by her nose, although the nasal relationship is not bad, you can see here that it reflects that retrusive maxilla. And so these are patients that we will often perform orthognathic surgery. I do Laford, sagittal split, genioplasty, I do it all. But in this patient, she didn't want to undergo orthodontia or braces. So as a result, we went ahead and corrected her by performing a rhinoplasty and a sliding genioplasty. And so you can see here that we can do a genioplasty setback procedure where we actually set back the chin and give her a better relationship in combination with rhinoplasty surgery. So again, genioplasty has the power to correct a retrusive chin, also the power to decrease an overprojected chin, as well as correct chin asymmetry and facial asymmetry in the lower third of the face in patients that don't want orthognathic surgery. You can see here again that she's very concave and she's more orthognathic or straight profile with this combination. Another one of my patients, sliding genioplasty and rhinoplasty. She had obstructive sleep apnea and microgenia, and so we did her rhinoplasty in combination with sliding genioplasty. She's 4 months post-op, and this is a video of this patient's operation. And so you can see here we mark out the midline. We use a sagittal saw. We open up, and you can see here the advancement. And then we use a step plate, as you can see here. And this patient got about an 8 millimeter advancement. And then we use screws and plates for fixation. I like using a burr to burr off the lateral corner because sometimes you can get a little step off. And you can see here the level of advancement that you can achieve in these patients. Now these patients are done at the same time as a rhinoplasty operation, and they're intubated during the surgery. Again, this is the same patient. Here's a midline estimation. Here, I like to make a cut here with an oscillating saw to match the midline, and then we do a full sagittal inferior ramus osteotomy. So it's a full bicortical cut of the mandible, and then we advance, and I like to shave off the little corners, make sure we don't have a step-off deformity. Step by step, this is a step plate here, anteriorly and superiorly. I like to put 6 millimeter screws, and I put the screws in the interdental papillae, which is the interdental gingiva, and I estimate the screw fixation between the cusp of the teeth. Now I go 5 millimeters below the tooth roots, and I make sure that we avoid the canines, but we still put these screws in the interdental papillae. Now inferiorly, this could be a 12 millimeter screw or a 10 millimeter screw. That's not a problem going bicortical. I just go unicortical on the superior aspect. This is that same patient, and you can see here rhinoplasty, a little nasal deprojection, just refinement. But you can see here how it actually improved her neck. Now, I would have loved to have done her facelift, and we could do a facelift at the same time even, but we did get some improvement in the neck as well as the jaw area. But what we were going for is for this anterior projection, and now she's more and more orthognathic or straight plane instead of this convex plane, which she was before. This combination of surgery also cured her sleep apnea to an AHI below 5. And we can speak about sleep apnea if you like in the discussion. This is her 3/4 view. You can see it's actually quite rejuvenating procedure as well. Like I said, I would have loved to have done a facelift for her, but in and of itself, it was quite rejuvenating. There's another patient who just did a genioplasty and augmentation for obstructive sleep apnea. He had mild obstructive sleep apnea. And so also retroussed the chin, and we did a sliding genioplasty. You can see here that he's more orthognathic, straight profile. We did not do a rhinoplasty for him, just a genioplasty. You could have done a chin implant as well in this patient, and that would have worked out fine, but the chin implant would have had to be greater than 1 centimeter chin implant. So with a sliding genioplasty, you can advance, and you can also give greater augmentation by putting a bone graft behind it. And so we did this for this patient. We gave him more projection. You can also bend the plate a little bit more anteriorly and give even more projection. So in these type of retrusive cases, I like to bone graft behind the sliding genioplasty and or rotate the plate anteriorly to aid in more projection. And I don't think I would be able to do that without doing a custom chin implant. A custom chin implant can give you that kind of projection, but then he's a young patient and you have to worry about tension. The other advantage about sliding genioplasty is that the incision's through the mouth, so there's no chin incision. And so for a younger patient that does not want a chin incision, a genioplasty is very helpful. So that's the end of my slideshow there. We're about 20 minutes in. So let's go back here and take any questions. Here we go. So we can take any questions as we go through this presentation, okay? All right. Next we have Tomas. Yes, Tomas.
Yes, I want to ask you something about that hyperprojected chin.
Yes.
Due to soft tissue.
Yes.
What kind of technique do you suggest?
Yes, to get to, you're saying a very retrusive chin in a young patient.
Not retrusive, a very projected.
Very projected chin.
Hyper projected. That's the thing I would ask, because it's an excellent result. And in my hands, it's difficult to have the result you had.
Well, thank you. I appreciate that. So
what do you do? What's the magic?
The magic, yeah. So this is where I see some people are actually taking a burr and just shaving off the chin. And I don't think that works. And the reason why it works, I've done 600-700 of these operations, and I've also done the genioglossal advancement, right, for sleep apnea. The reason why I think that shaving off with a burr is not good is because the cortex, I've published several papers on this, the cortex is, the bicortical area is anywhere from 8 millimeters to 15 millimeters. And you just don't know. You know, and so as you shave down, you're going to get into marrow and bleeding bone. And so you don't want to shave down only. And so because of that, what I do is actually do a sliding genioplasty setback procedure where, just like I showed you, I am cutting the chin right below the canine, and I'm tapering it up. And then as I do that, I set it back. And as I set it back, I'm not going to use a step plate. I'm actually going to use a lag screw. So I'm going to put 2 lag screws going from superiorly, inferiorly. The outer cortex of the lag screw is going to be mesial, or in maxillofacial surgery we say mesial, but it's going to be medial to the canine. It's going to be angled down. The outer cortex is going to be a 2.0 drill bit. Okay, to open up that cortex, and then once I set back the chin, the distal chin is going to be 1.5 millimeters, and so then I put a 2.0 screw by 10 millimeters. So 2.0 screw is going to be slightly angled downward because I don't want to angle up towards the tooth root. It's going to be slightly angled downward on both sides, but because it's a lag screw, is going to capture the smaller diameter drill hole of the distal segment. And so it's going to compress that distal segment up. So again, I'm going to do a sliding genioplasty. I'm going to set it back the way I want. I'm going to do the outer cortex with a 2.0 drill bit, the inner cortex or the distal segment 1.0 drill bit. And then before I put my screws in, I'm going to take a burr and I'm going to shave down the proximal segment, which is containing the teeth. And I'm going to shave that to match my supramental crease to where I want it. And then I put the screws in last. And that will cause that chin point to compress.
And the soft tissue.
And then soft tissue. So then there's going to be, I open up, I widely undermine, and I detach the mentalis muscle, right? And now the whole thing is flail, right? And open. Then afterwards, you have to reattach the mentalis muscle. And I use a 3-0 chromic on a UR6 needle. I used to use an SH needle, but it would bend the needle because the plane of the mandible, it would bend the needle. So if you use a UR6, it's a urologic needle, it won't bend, and it's tapered. And so then I get the distal mentalis muscle and I approximate. And then as I approximate, I'm redraping the skin, right? And then the gingiva that's remaining, I'm going to suture with the UR6 needle in the interdental papillae so that I don't get any gingival recession. Because if you don't, you'll get gingival recession, and then they have to go see a periodontist, and they don't want to do that. So And then
very nice.
I hope my fellows and residents are watching, so I don't have to explain again what leg screw is.
Yeah, it'll be recorded on YouTube. You can go back to YouTube and watch.
Great.
Yeah.
Great, Jose. Congratulations.
Thank you, Tomas. Thank you.
Very nice case.
Tomas, I'm interested now for you to take this to the next step, and that is, how are you addressing the overprojected nose?
Yes, I will talk a little bit about reducing the dorsum. Let me just put my lecture here. And how do I adjust my profile?
Yes.
Well,
and we should be streaming. I see that lots of comments. Any questions that you have, please go ahead and ask them, and we'll get to them at the end.
You see my lecture?
Not yet.
Not yet? Well, it's here.
Okay, I see it now. Yes.
Oh yeah?
Yes.
Well, so I think I'll have to do it without seeing you guys.
Okay, yeah, that's how mine worked. I couldn't see you, but I can see the lecture and I can see you. Okay,
I will talk about a little bit about dorsal reduction and how I do and how do I adjust my profile. It's a little 70% of my patients come today to my office asking for a dorsal reduction. I don't like my hump. I want my hump to take down, and we all know that we can have complications by reducing the dorsum. A lot of secondary rhinoplasties patients come to our office with those problems, like interrupted aesthetic lines, as you can see here in the photo, inverted V deformity, and the middle vault collapse. So it's a problem. It's a aesthetic problem and also a functional problem. 10% of patients after rhinoplasty complains about nasal obstruction. Nasal valves problem are more common than the septum problems. It's 4 times in primary rhinoplasty and 12 times in secondary rhinoplasty. Here is what we used to do in the past, a composite reduction. And what do we do now? It's a component reduction. In the past, when you do the remove of the dorsum, there was an inframedial displacement of the upper lateral cartilage, and all those problems come in a year or less. This is a patient I operated on 12 years ago, my last year of residency. And here is the photo of her profile 4 years after surgery.
Mm-hmm.
I like her profile. She had a dorsal hump with a little bit ptotic tip. I did a 3 millimeters dorsal reduction with lateral crural steel and a strut. I didn't use spreader grafts, nothing like that. And then 4 years after surgery, we can see some irregularities in the dorsum, a narrow middle vault, and no dorsal aesthetic lines. So started doing a progressive reduction individualized by structures and reconstructing the dorsum after this. It's a structural concept. We use outer spreader grafts to reconstruct the middle vault and to protect and form dorsal aesthetic lines. Here you can see some images showing an outer spreader graft. But there's some studies showing that the outer spreader, there is no functional improvement. And also in my practice, I see that in long term, you can lose that dorsal aesthetic lines using just the auto spreader. So in my opinion, you should not use the auto spreader alone. If you use it, you should use with a spreader graft. And here, other studies showing the importance of the spreader graft. It's a functional graft. You can have improvement of your airflow, and the visual analog scale also increased, and also you can see here a study with level of evidence 2B showing resistance decreased by 52.9%. So the spreader graft nowadays, it's considered a functional graft, and I use it to improve this.
Mm-hmm.
When do I use the spreader grafts? In short bones, 12 to 13 millimeters. I always measure the upper lateral to the upper lateral, like 8 millimeters. I try to leave it the same length after the surgery. And I use those spreader grafts a little bit stronger in the cephalic portion, and as it goes caudal, you can put it a little bit smaller. As you can see, 2 millimeters, 1 millimeters in the middle, and 0.5 at the end. Here's a case of mine showing those polygonals Baris Chaker described. And here I'm doing the spreader with septal cartilage. And as you will see, I leave a little bit stronger cephalic. All the borders are beveled also. And here we are, both spreader grafts. I use it as with the setback methods. I put it 1 millimeters below the cartilaginous dorsum, and the upper laterals come above them, suturing it. It maximally stabilizes the upper lateral cartilage and avoid excessive wide middle vault also. So there are some steps to do this. It's a structural preservation approach, and you will see why. I use a subperichondral subperiosteal dissection. Then I'll do a paraseptal incision. You will see the dorsal reduction, cartilaginous bone. I use the piezo. I do the upper laterals reduction. I use the spreader graft setback, and I do the upper lateral tensional spanning suture. Here's a dissection, one of the dissections that I did, showing the limited dissection that I do. I preserve the vertical scroll ligament. I do it under the perichondral also. Here you can see intraoperatively in a surgery showing the perichondral ino ear, the vertical scroll ligament preserved. Here just showing that tissue, that perichondral tissue on the dorsum. It's very strong, and you should preserve it. Here's a quick video of me doing this dissection. Here you can see the Pitangui ligament. I will remove it to access all the dorsum. At the end of the surgery, I can reconnect it. Oops. Oops. I don't know where my lecture ends. Like here. Hey guys.
Yes.
Are you seeing? Are you seeing? I'm not seeing anymore. Here.
Yes.
Here you go.
It just froze for a small amount of time.
Sorry. Here I'm going subperichondral. And here I want to show this. I mark the wassa, and then I do some incisions to separate the cartilage from the perichondrium.
Mm-hmm.
So I will separate only the cartilage separately. As you can see here, only the cartilage separate. And then I will release the mucosa. That's it. So then I will do the dorsal cartilaginous reduction. I mark the amount that I wanted to take out. And then with the 15 blade, 11 blade, I cut it. I cut it out. That's it. Then I'll do the bone reduction with the piezo. I'm using it, I think, for 2 years now, and it's perfect, I think. And then I use the spreader grafts. Here I'm using the setback method, as you can see, 1 millimeter below the cartilaginous dorsum, and I'm suturing it with a PDS suture. This one is a 660 PDS suture. And then I'm suturing here. I want to show this. I'm suturing the upper lateral to the dorsum, and you can see my my little hooks here pushing the cartilage caudal to give some tension to the upper lateral. This is very important. Sorry. And then I'm suturing with a new stitch. You suture, and that's it. Here is the article Hark wrote about this tension and expanding suture. Here is just a picture showing the spreader graft setback. And here at the end of the surgery, at the end of the dorsum surgery, as you can see, limited dissection with the preservation of the structures, the vertical stroke ligaments preserved, and the ULC is reinserted. You can see here 10 days after surgery that the skin is loose, there's no irregularities. And here's some cases. I'm just finishing. Here's some cases. Here's a patient. I did a 2 millimeters dorsal reduction with spreader graft, lateral steel with a septal extension graft 1 year after surgery. As you can see, her profile, frontal veil with no irregularities. The dorsal static lines is there. Another patient with a cartilaginous dorsal hump, a long caudal septum, and a pitotic tip. I did a 3 millimeters dorsal reduction. I used spreader grafts, lateral steel, and a tonguing groove. She had a long caudal septum. That's why I used the tonguing groove technique here. Here she is. You can see the dorsal static lines preserved. No irregularities. Another patient, she has a short nasal bones. You can imagine that looking her frontal view photo. She had short caudal septum also. So I did a 2 millimeters reduction, spreader grafts, and I used the lateral crural with the septal extension graft. And here she is 10 months after surgery, as you can see here, months after, with the good profile view. Here is a patient showing her post-op, 1 year post-op. And here you will see her maintaining the dorsal aesthetic lines. 5 days, the same patient with 5 days, 3 months, 1 year, 3 years, maintaining the dorsal aesthetic lines. Another patient using spreader grafts, look at her profile view. I love this 3/4 view. And here she is maintaining the dorsal aesthetic lines long term. 1 month, 3 months, 6 months, 2 years, 3 years, 5 years. There's still a dorsal aesthetic lines. Another patient with a dorsal hump and a ptotic tip. I did a 3 millimeter dorsal reduction with spreader grafts, lateral crural and septal extension graft. Here she is 1 year after surgery, 1 year after surgery, maintaining the dorsal aesthetic lines. And here a close-up view, pre-op, 1 month and 1 year after surgery. Same thing at the lateral view. And the last one, patient with a dorsal hump, long caudal septum, ptotic tip, low radix. And this patient I did 3 millimeters dorsal reduction, spreader graft, and radix augmentation with free diced cartilage. Lateral crural and a tonguing groove. She had a long caudal septum, that's why. And here she is 1 month, 3 months, 6 months, 1 year after surgery, pre and 1 year after surgery, maintaining the dorsal aesthetic lines. As you can see in this close-up view. Profile view, 1 month, 3 months, 6 months, 1 year. Here she is 1 year after surgery, maintaining no irregularities and maintaining a good aesthetic dorsal lines. So works for me. Dorsal reduction, the limited dissection and structural preservation. I did a subperchondral superiosteal dissection, paraseptal incision, dorsal reduction, the ULC reduction if needed, spreader graft setback, and the tension spanning suture of the upper lateral cartilage. That's it.
Beautiful, Tomas. Beautiful. Thank you.
Thank you, José.
Tomas, a question for you. When you use your piezo for the dorsal reduction, are you using a diamond burr or a cutting burr? What kind of burr are you using?
It's not the diamond burr. It's like a claw.
Okay.
See, it's like a claw. Yeah, it's like a claw, and I rasp it. Very delicate, and I rasp all the dorsum. I like to use it a lot for the lateral bones also.
Yes.
You see, the lateral bony cap. Yes, the lateral bony cap. It's much more delicate than a rasp or a burr, other kind of burr.
Yes. No, it looks. You have some very nice results. I also like how, like you said, you're preserving the ligaments, right? And
yes,
with postoperative swelling and recovery as well.
Yes, it's a very limited dissection. I do a very limited dissection. I know that there's a lot of guys doing full open dissection and removing everything and then reconstructing it all. I prefer to do a limited dissection, leave the structures where they are, and do my job.
Yes.
Prefer to. Yeah.
Excellent. Congratulations.
Thank you, José.
Dr. Gomez had a question. He said, "What is your impression about long-term bone resorption with silicone implants?" You know, I don't.
Geraldo is an ENT, a facial plastic surgeon from Rio. A very nice guy.
I love Rio. I visited Rio 2 years ago.
To come to Rio.
Yes, I'd love to go back. I love Baja and some good food. I've seen silicone implants resorb the anterior chin point, and usually occurs acutely, and it's due to lack of fixation. So if there's lack of fixation, a lot of movement, you can get resorption. I've seen it so to the point where I've seen tooth roots exposed. At that point, and I've done this case where I have to, in order to remedy that, you have to take out the implant. You have to take a iliac crest bone marrow. So you make an incision in the iliac crest, take bone marrow, you pack the bone marrow, and then you also do a sliding genioplasty to correct the deficit. So I think that's the correction is much bigger operation. So it's just better to, when you place it in a tight pocket. I don't use the button implant because the button implant could lead to more resorption. So something like an extended anatomic chin, which Implant Tech makes. I have no affiliation, no disclosures. Or doing something like Middleman. Dr. Middleman has his own implant, which is a Middleman pre-jowl chin, which gives you more facial height, about 1.5 centimeters facial height and 1 centimeter projection on a medium implant. But using a more robust implant that could be very placed in a tight pocket and fixated would help to alleviate some of that problem. And then Dr. Arturo Carpes.
Arturo is a ENT, CMF, and sleep surgeon.
Wonderful.
A very experienced guy in sleep surgery.
Wonderful. Thank you, Dr. Carpes, for your question. How do you plan the chin osteotomy for OSAS in relationship to the epiphysis, genial, and dental roots? So typically, if it's an obstructive sleep apnea case, we're doing soft tissue surgery like a glossectomy and palate surgery as a phase 1. We're doing orthognathic surgery as a phase 2. In patients with upper airway resistance syndrome, mostly females with microgenia, we will do a sliding genioplasty on. The success rate's lower. It's about 40% success. But I've written 3 papers on genioglossus advancement surgery. This is probably a better operation. Success rate's about 61, 62%. And it really has to do with how much tension to width ratio, how much width advancement you can give them to the tension of the genioglossus muscle. And so we wrote a paper about tension to width ratio and what the proper ratio should be. But to answer your question, I like doing a genioglossus advancement for these patients. If we're going to do bony surgery before orthognathic surgery, and then I go mesial to the canine, 1 centimeter below the canine, but I approximate we should have 1 centimeter of the border. So you should have a 1 centimeter border, 1 centimeter below tooth 7, 8, 9, 10, and mesial to the canine. And there was a nice Taiwanese paper that described this relationship that's in the literature. But if you don't have that vertical height, then a genioplasty may be the only thing you can do. And you could even do what's called a mortised genioplasty, which is a genioplasty that comes up and has a little vertical segment like a genioglossus advancement. I don't like that operation as much as a genioglossus advancement, and the success rate in the meta-analysis shows that it's not as good as a genioglossus advancement, but it's still a good operation if you want both aesthetic and you want maximal advancement. I just don't like it because then you have a very large segment which is hard to stabilize afterwards. And it's all about, in craniofacial surgery, craniomaxillofacial surgery, it's all about stability with your plates for good healing.
And on those MMA cases that you do at the same time, genioplasty, do you do any different, the osteotomy? Do you put it higher, your design is more oblique or something like that? No.
Yeah, it depends on, honestly, it depends on the ethnicity of the patient. So for example, Asian patients, typically I don't do a tapered Lafort. I do a more stepwise Lafort, so to not give them too much mid-face projection. The sagital split is about the same, but we do a virtual plan. We do a minimum 8 millimeter advancement, and then we kind of rotate at least 3 to 5 millimeters to impact the maxilla. And the genioplasty, we do it purely for aesthetics at that point, and we're doing it with an MMA because the MMA should take care of the airway.
Okay.
So now we have Dr. Lucas, who's going to present his experience on orthognathic surgery and genioplasty, as well as what he does to correct some of these facial abnormalities in patients who also present with rhinoplasty.
Okay. Do you see me, guys?
Yes, let me bring it in. Rhinoplasty. Yes, I can see you. I can see the lecture. Can you?
Tomas?
Yes, yes.
Okay, so I'll go. I'll talk a bit about rhinoplasty and other cosmetic bone surgery. The most powerful bony surgery is orthognathic surgery. We can do other small surgeries, but anyway, the skeletal surgeries are still controversial because the unpredictability of the position of the maxilla or other structures surrounding the nose can make the rhinoplasty a bit unpredictable too. So some surgeons prefer to delay the rhinoplasty for a secondary surgery, for a second time surgery. But on the other hand, we see that our patients are very concerned about their happiness, and the facial balance is important for happiness. I talk to my patients that happiness is expectations versus reality. So if we can meet their expectations, they're going to be happy. And that's what we do when we do a complete facial workup. We can do rhinoplasty, we can do forehead, chin, malar, or orthognathic. I'll talk about three important surgeries: the genioplasty, the orthognathic, and the facial feminization surgeries. The three surgeries that I do most commonly with the same simultaneously with rhinoplasty. The genioplasty, we talk a bit about here implant versus osteotomy. The implants, we have two good options: the Mapor and the Silastic. Most of my patients that we do implants are Silastic. It's an easy operation. It's a labial incision. It's an office-based procedure, just a small pocket, and I usually make a cut in the midline so I can be sure that they're fit in the midline to the teeth. Here's a patient that I did rhinoplasty and a Silastic implant, a foot plate suture, and there's a reduction and a bit of rotation. I do like the implants for female, young female, that need just a small augmentation. For patients that need more augmentation, I prefer sliding genioplasty. And at the same time, we can do a 3-dimension reposition of the chin. It's not an advancement. As Jose has showed us, we can do a setback, we can shorten the face, we can lengthen the face, and we can also correct coronal asymmetries. I usually use the same osteotomy that Jose has showed us. It's a basilar osteotomy, and we reposition the chin and fix with plates and screws. The anterior position is very nice because we pull all the muscles, as Arturo has asked. It's very important to pull the muscles, the genioglossus muscles, so we can open the pharynx. And these patients, so they have two important things. They have a better aesthetics and they have a better breathing. I usually use the same plate, the striker one, that Labinger striker that Jose showed us. I usually use the same one. Here are some of the Depuis synthesis plates, which are very nice too. There's option to use screws too. And here's the patient on his x-rays on profile view. And that's the patient. In this patient, I did a 10 millimeter advancement, and you can see how the neck improves. And at the same time, I did a rhinoplasty with dorsal reduction. Mm-hmm. We can also set back the chin, as Jose has showed us. We can put the same plate backwards, or use L plates, or as he has explained us, with leg screws. And that's one patient that I did this. what I asked him is that soft tissue is very difficult to adapt when we do setbacks. So it's not a good operation. I'm not eager to do this operation, but in some patients, like in this guy, I did a rhinoplasty, dorsal reduction, a better tip refinement, and projection, and I had to reduce the chin a bit. And he's very happy. I'm not happy at all. The labial mental sulcus sometimes get a little, a bit artificial, and a bit of in the neck, a fullness in the neck. But anyway, the augmentation chin surgeries are much better, like the vertical lengthening. For patients that have short face, I usually use mastoid bone autograft to fill the gap, and that's a patient that we did rhinoplasty and chin augmentation on the vertical and also on sagittal. Here's her smile and her own profile view. A better dorsal, a better projection of the chin and the nose. And here are the x-rays. Here's the mastoid bone autograft. We can also shorten the face. It's a good operation, but not as good as when we stretch tissue. So here are some options of fixation of the chin. And here's a patient that I reduce the length of the face. I usually try to combine lengthening with advancement. For example, so I don't have soft tissue excess, or maybe setting back and augmenting the face. So I don't have that much of soft tissue excess. But anyway, always augmenting is better than reducing. And finally, we can correct coronal asymmetries. Like in this patient, we correct the chin, and we did a rhinoplasty. We did domal suturing. Here, the base view, we can see the chin is much more centered on 3/4 views and on profile dorsal reduction, and a bit of advancement too. Well, the second surgery that we can do at the same time, simultaneously, to rhinoplasty is orthognathic surgery. I think it's interesting to do both at the same time because of the functional airway and the patient satisfaction. There are two important things that we can do. On the other hand, the orthognathic surgery, there are a lot of adverse effects of the orthognathic surgery to the nose. This is a table that we can see most of the effects on the alar base, projection, rotation, supratip, and dorsum. I'm going to show you some few cases, but it is a case that had a patient that came to us for rhinoplasty. She had a orthognathic surgery before, and she has most of the adverse effects that we can have on orthognathic surgery. She has a low dorsum, widened alar base, a loss of definition of the tip, saddle, an over-projected tip. So a lot of adverse effects that could be avoided if we had a rhinoplasty at the same time. Checking again, when we rotate, when we reposition the maxilla anterior superior, we rotate the tip, and when we reposition it inferior, the tip will droop. Like in this patient, we advanced it, and she had a slight tip rotation, and it, for her, was beneficial. In this guy, we did an MMA, and he had a slight rotation of the tip too, which was fairly beneficial, but we could have bad results in some cases. The nasal dorsum, when we put the maxilla up, we usually get a hump, and when we put down and forward, we usually have a saddle. In this guy, we did a maxilla advancement without rhinoplasty, and the saddle and the hump has gone. So for him, we did not do rhinoplasty. In this patient, MMA patient, she has a saddle. For her was not good. She doesn't care, but it's very it's a thing that we didn't want that to happen. And the alar base, what we usually have is widening and asymmetries, like in this patient, another MMA patient. Mm-hmm. So I usually try to do the two surgeries at the same time. That's my surgical sequence. I usually do, it's important to do the orthognathic surgery first, and then the rhinoplasty. So we usually have a nasal tracheal intubation and draping. We do the orthognathic surgery, lift for one, sagittal split, osteotomy, chin, and then we convert the nasal to oral tracheal intubation. I usually don't do another intubation. I use the same tube. I use opening mouth and 2 Kelly clamps. One clamp, I hold the tube on the hypopharynx and the larynx, and my assistant, he pulls the tube through the nasopharynx, and I can pull the tube with another Kelly clamp. So the airway is guaranteed. We don't need a second intubation. And here we just connect to the airway again. So it's quick. It's like maybe 30 or 30 seconds, 60 seconds, and we are ready to go to the rhinoplasty operation. The most important step for me in rhinoplasty is to reestablish the L strut. So resuturing the L strut to the interior nasal spine is very important. I usually take my graft at this step, like this. So I usually do the anterior septum dissection first. I do both flaps, the mucopericondal mucosal flaps on both sides of the septum. Mm-hmm. And I mark where I will take my graft off. So here, and I can check my projection and rotation if I may. So here I decide that I will leave 2 centimeters of caudal septum. And so from that cut backwards, I can take all the graft I need. I usually put a hole on the interior nasal spine and put a figure of 8 of suture to fix the nasal septum. Usually in my patients, I use a septoextension graft to establish the nasal tip. And I really like using bones as splints, so the graft doesn't tilt to one side or to the other. And doing orthognathic surgery is a great opportunity to have bone grafts. I usually take my splint grafts from the medial maxillary wall, as we can see here in this video. I use a piezo so I can cut the medial wall of the maxillary sinus and on one side or both sides. And this bone is very nice for spleening because it's extremely thin and at the same time it's strong. I can take the bone from the perpendicular plate to here in the vomer. So I have a lot of amount of bone for splinting the septoextension graft. I use the burr to do a multiple perforations, and then I usually put a small piece of this bone on the posterior septal angle before suturing to the nasal spine. When I feel that the septum is not strong enough to withstand the fibrosis and the movements that I want to do. So here I have a stronger septum that can stand everything that I plan. And the final tip, I don't do cinch surgery, cinch suture when I do orthognathic and rhinoplasty at the same time because I don't rely on this suture or I don't know how to do it very well. I hope Jose has a magic tip. So I prefer to reduce the dorsum doing alar base reduction the original way. Mm-hmm. I'm going to show some few cases. She's has a vertical excess and a maxilla hypoplasia. For her, I did only maxilla advancement and chin reduction, and rhinoplasty, lateral crural steel with a columellar strut, ailerines, dorsal reduction, lateral osteotomies. I put her on her iliac crest bone grafts because of the advancement, and that's her with a shorter face, a better lip relationship, a nicer tip, better smile. On profile view, we have a better dorsum with a better rotation of the tip and a relationship to the chin. And her smiling is very nice too. Her final occlusion. For long faces, it's a good option to do rhinoplasty at the same time because the movement is very big. In this patient, for example, and she had a ptotic tip. So in this patient, I had a 6 millimeter impaction. Sometimes we have to do 10, 12 millimeter impaction. So this disturbs the nose a lot. So for her, I did a close approach with a columellar strut, a cap graft, dorsal reduction, and foot plate suture. That's her with veneer follow-up, a nicer tip, very refined tip, better symmetry, better lip closer. The tip is more defined. And on profile view, we could add support to the tip with the columellar strut so we can lower the dorsum and make her have a better profile. Her smile. These patients usually have a nasal spine that's strong enough so you can use columellar strut. Usually, not all, but usually. This patient is anterior open bite with external valve insufficiency. For him, I did a maxilla only surgery and seagull wing graft. And that's him after surgery. He has a shorter face now because of the closure of the open bite. He has a better external nasal valve. He's smiling here. A better nasal base and a better profile. I also did a bit of rotation of the tip and a bit of dorsal reduction. And a last case, a class 3 with prognatism and maxilla hypoplasia. He had a very ptotic tip, and so we decided to do rhinoplasty and orthognathic at the same time. Here, the occlusion, and here he's just prepared for the surgery. He had a 14 millimeter overjet. So it's a big overjet. We did a combined surgery, maxilla mandible, but we did not do chin. Here's our virtual planing. Here are the osteotomies, the soft tissue planing, and our splints. I use it on him also iliac crest bone grafts. Here's the soft tissue simulation. We were happy with the simulation at the time. And we did a 8 millimeter maxilla advancement with inferior positioning, a setback of the mandible, and a lateral crural steel with a columellar strut, and alar ring grafts and alar base reduction. That's the surgery here. We did, as Jose has said, a higher osteotomy with a step, so we could get a bit more of the enhancement on the malar region. Here's the intermediate splint, fixation, the final splint, and the mandible fixation. And as I said, we did not do chin surgery. That's in, and we could correct the asymmetry. We could reduce the length of the nose and the face. The smile is much more it's much better. On profile, we have a better rotation of the tip and a nicer dorsum. And that's the occlusion.
Nice.
I really like the third surgery that I'm going to talk about, which is facial feminization. We have a lot of patients here in Brazil. There are not that much surgeons that do facial feminization. So I receive a lot of patients from all over the country and abroad. And I love to do frontal osteoplasty and mandibular osteoplasty. The mandibular osteoplasty, I usually take the angle off or just reduce the width of the angle. This is a patient, an example that we did the mandibular angle reduction. She is much thinner or narrow, I can say. On 3/4 view, we can see that the angle is softer now, it's more feminine. And her on profile view with a better and more refined mandible. And the frontal, there are a lot of techniques. The most common is just reducing the frontal bone. We can set back the frontal bone too. It depends on the size of the frontal sinus. Here's a video showing a conventional frontal bone reduction. I usually do a zigzag incision for coronal approach. I usually dissect on the supra periosteal plane, subgaleal plane. So I leave the periosteum flap if anything happens. If a disaster happens, I have a plan B. Here I'm leaving, I'm separating the orbits, and here I'm reducing the orbital rim on both sides. I usually begin with the orbital rings, then the nasal frenal angle. It's very important to reduce the nasal frenal angle, and then the frontal zygomatic suture, and then the frontal bone itself to soften everything, as we can see here with a cylindric bore. I check if everything is the way I think it's okay. I will put some sutures to lift the eyebrows. Usually my patients, they like the tail of the eyebrow very, very, very high. So I put 2-3 surgeries to lift the eyebrows too, and suture. And that's a patient. She had a previous rhinoplasty before. I did a secondary rhinoplasty with coastal cartilage. We could get a better refined tip. We reduced the orbital rings and the forehead as a whole. I reduced the mandibular angles too. That's her base view with a better nostril symmetry. And that's her on profile view. I could get her a better rotation and projection of the tip, and a big reduction of the frontal bone. And so now we have a better and more feminine face. Mm-hmm. That's her 3/4 view. Here too, a better projection of the tip and a reduction of the projection of the forehead. That's her on 3/4 view. So it's a very nice operation to do the 3 at the same time. The patients usually love the results because it's something that really feminized as a whole. So my final comments, it's that doing rhinoplasty with any other cosmetic facial bone usually promotes good results. And the satisfaction rates are usually higher than doing it one surgery by itself. I don't know why. I think patients become happier. That's what I said on the beginning, that expectations, when they can come to reality, it's happiness. But it's important to have a correct surgical planning, especially in orthognathic surgery, and to restructure the L-strut. Otherwise, we're gonna have we're not gonna have good long-term results. Here are my social media. So if any of the audience want to contact me and ask some questions. And now, José, your suggestions.
Beautiful, beautiful presentation, Lucas. Thank you so much. You covered a lot of ground in a very little amount of time. So each of those topics could be a lecture by themselves. So thank you so much. So some questions, we'll finish up here. Dr. Capuchinho, is asking, do you do any kind of different taping after genioplasty? And I use a Job's dressing, which is like a jaw bra, and I use that for 2 weeks, day and night, and then only at night for a week. I tell patients it's going to be 6 weeks you get osteosynthesis, and so the jaw bra kind of holds things in place for the time being, and I think that helps. But I don't do any taping now, just a jaw bra. How about you, Lucas or Tomas? You do any taping after genioplasty or chin implant?
I do taping for 2 days only. I don't do any bra anymore. I do use a bra when I do liposuction.
Okay.
Or facelift.
Very good.
Yeah, the same thing. Same thing for me.
Excellent. Dr. Martins, for Lucas.
Em português.
A tal distância de raiz de dentro a fratura pode chegar.
Yeah. It's asking how low you should be to avoid damaging the tooth roots. 5 millimeters, it's okay, but if you keep it 1 centimeter, it's better.
Yeah.
And then there's a question for Tomas from Dr. Martins as well.
He's asking about the dorsal preservation instead of opening the dorsum and using spreader grafts. I don't use the let down, push down maneuvers. I like to preserve the soft tissue, so it's kind of a preservation. But I don't do let down or push down. I use the regular osteotomies, lateral osteotomies, and I reduce the bony cap with the piezo. There's another question here from Valdir Carreirão. He's asking, can you preserve the vertical scroll ligaments even when you need to use the piezo to perform the lateral osteotomies? I don't use the piezo. Yes, that's it. I don't use the piezo to perform the lateral osteotomies. I use the Cinzel, the osteotomy. Yep. I use it. So I only do that dissection, that limited dissection. I use the piezo only to remove the bony cap and anything I want from the bony dorsum, not to do the osteotomy. That's why I don't release the scroll ligaments.
Yeah, it's not possible.
I don't think so. Yeah.
No, it is not. If you want to use piezo to do the osteotomies, you have to do the full open access.
Yes.
Otherwise, you cannot reach the maxilla groove, because the osteotomy is not on the nasal bones; it's on the frontal branch of the maxilla. But there are a lot of surgeons that advise that you cut the ligaments when you in some special rhinoplasty surgeries, like, for example, when you have broad, like Rick Davis talks about, when you have a lot of broad and wide nose tip, you have to cut these ligaments. Otherwise, you won't have a good result in refining the tip. That's a discussion.
Yep.
So another question, Dr. Gomez. I think let's start here. When the patient had a prior maxillary advancement and it comes for rhinoplasty, should we have special care when performing the lateral osteotomies? I would say if they've had a prior maxillary advancement, then they're healed. And so I don't have a problem with redoing an osteotomy. And so as long as they're healed and it's not a problem. Now it's different when you're doing rhinoplasty at the same time as a Lafort. That is, and you're going to do lateral osteotomies. That is very different because you're actually cutting from the piriform aperture of the maxilla, right, along the facial groove all the way to the pterygomandibular raphe, and you won't be able to do lateral osteotomies with an acutely fractured maxilla at that point. Another question here from Dr. Vargas. How do you deal with mild chin implant malposition? I would say personally, I would have to remove the implant and replace the implant. It is very difficult to shift it once the patient is closed. And Lucas, I like your approach of going through the mouth. Do you find that easier to avoid implant malposition going through the mouth?
I prefer doing through the mouth. I'm always trained to oral surgery, so I always did my implants intraorally. And I can tell in the 17 years I had to remove one implant that the patient had a psychiatric crisis. And with 7 days, he came to my office and said, "No, I'm happy. My chin is nice." I took his photograph, said, "But I don't want an implant." And I called his parents and said, "No, he's crazy. You have to take his implant off." Okay, I took it. And 3 years later, he came back, said, "Doctor, I went to the psychiatrist. I had a problem. Sorry. Excuses. I want to put the implant again." I said, no way. He said, "No, I have a letter from my psychiatrist. You have to put my chin again." Okay. And when I just got to the OR, he said, "Doctor, I'm having the same feeling again. I don't think we should put this implant." And he left him.
Yeah.
So I'm okay with putting the implants intraorally.
Yeah.
Okay.
I had one patient, a male. He came for a rhinoplasty and chin implant. I did both. And after 3 months, he came back and asked me to remove the chin implant. I removed it. And I think six years later, he came to me, but not as a male, but as a woman. And I think that's why he asked me to remove it at that time. And he came back to me and asked me to do again her rhinoplasty now. And I did at this year, beginning of the year, I did the rhinoplasty, creating a more feminized nose. Yes, it was very interesting.
And I think too, you want to with the sizing, you want to make sure that the chin implants are not oversized for the patient, and so if you're putting too big of an implant and you're distorting the face, it's too much of a change. It's too, so you have to be careful that you don't project the chin too much. Same thing with genioplasty. I tend to be on the more conservative side. It's, I tend not to bone graft. I tend to go 6 to 8 millimeters, not more than that, because I think it could be too distorting for the patient maybe.
I agree.
So I think that's all the questions that we have. Yeah, so
okay.
It's been a wonderful time with both of you. I wish we can do this in Rio one day, anywhere in Brazil. Say again?
In San Antonio.
We should do it in San Antonio. If we do it in San Antonio, we could do live surgery in my surgery center.
I'm close to.
There you go. That would be excellent. Well, I just want to thank you so much, Lucas and Tomas, for joining me. I look forward to seeing you in Orlando next year.
Yeah.
And I think that
we'll be there.
A wonderful time.
Yeah. Thank you very much, Jose.
Thank you.
Wonderful time. Thank you for inviting us.
Thanks for having us.
Yes. And I invite all your colleagues from Brazil to come to the rhinoplasty course in Orlando in May of 2021. So
we'll be there.
It'll be fun.
Yes, I'm sure we'll be there.
For sure, there will be a lot of Brazilians there.
Yeah. Take care.
Thank you. Bye-bye.
Thank you. Bye.